Good morning, everyone. My name is Benjamin Crowley, and I really appreciate this opportunity to be able to provide critical analysis of a paper that I believe is highly relevant to the population analysis and planning team here at the North Queensland Primary Health Network. The article I would like to present to you today is Estimating the Economic Costs of Skin Cancers in New South Wales, Australia, by Christopher Doran from the University of Newcastle. The study provides background around the prevalence of skin cancers, with Australia and New Zealand having the highest incident rates of skin cancers worldwide. They also describe the causes of skin cancers, which are predominantly solar UV radiation. They go on to describe the types of cancers, which are melanoma and non-melanoma, the treatments, diagnosis, and follow-up schedules. They then segue into the economic impact, the direct costs, which are the management of skin cancers, the diagnosis, treatment, follow-up, and all the healthcare resources, and the indirect costs, the loss of productivity, morbidity costs such as sick leave, early retirement, and premature mortality. They did a literature review where they identified 11 articles which analysed direct costs, 2 articles which looked into the indirect costs, and 4 articles which looked into both indirect and direct costs. One was in the UK, one was in Sweden that was later repeated, and another in New Zealand. The article clearly states the objectives of estimating the economic cost, both direct and indirect, of skin cancers in New South Wales. And they also hope that the article will be used as evidence to inform future planning and development of skin cancer prevention strategies. They took an incidence-based approach to estimating the economic costs. This allowed them to follow the cohort for the duration of disease and estimate the discounted costs. This is a really good approach because it allows policymakers to understand the impact of reducing the burden of the disease. So based on this, Doran et al. Conducted the study as an economic impact analysis or a cost of illness analysis. In the public health model for prevention, cost of illness analysis often fall within the measuring the burden of disease or illness. So the authors have done this using linked data from a number of sources, including the 45 and up study, the Australian Bureau of Statistics, pharmaceutical benefit schemes, and other sources which are listed here. From this, they were able to calculate average lifetime costs, as well as synthesize indirect costs, such as morbidity, premature mortality, from melanoma and non-melanoma skin cancers. These were then used to calculate the costs of resources to treat the diseases and the losses in productivity to society because of skin cancers. So the burden of the skin cancers. In 2010, Doran et al. Identified 152,000 new cases of skin cancers. Nearly 4,000 of those were melanomas, and the other 148,000 were non-melanoma skin cancers. Both types of skin cancers were split between males and females 60-40. 514 patients died of melanoma, and another 145 died from non-melanoma skin cancers. Those who died from melanoma, the potential years of life lost were 9.34 for males and 10.14 years for females, compared to 5.44 and 2.53 for non-melanomas, respectively, which indicated that men are dying earlier from non-melanoma skin cancers than women, while the rate is relatively even for melanomas. The lifetime economic cost of skin cancers for all cases was $536 million. Of this, the nearly 4,000 melanoma cases cost $171 million, while the 148,000 non-melanoma skin cancers cost a staggering $365 million. Delving deeper into this, the direct costs for melanoma were relatively low at 22%, compared to the 95% for non-melanoma skin cancers. As melanomas have a greater impact on the patient after the initial treatment, i.e. the direct cost, the indirect costs hit harder and account for 77% compared to only 5% for the non-melanoma skin cancers. The low direct costs and high incident rates of non-melanoma skin cancers resulted in them accounting for the majority of the financial burden. It was particularly interesting to see that the direct costs for females with non-melanoma skin cancers were nearly double what it is for males, especially when there's only a 15% difference between males and females. This could be because women are more conscious of their skin and seek treatment immediately, while men tend to have multiple non-melanoma skin cancers treated at once, thus the increasing in incidence while the lower costs for males. The strengths of this paper are threefold. They are the first Australian paper which analyses the economic impact of skin cancer, both directly and indirectly. This sets the stage and allows others to directly apply their findings to their region, state or territory to develop and implement policies to reduce the prevalence of skin cancers. Alternatively, researchers can duplicate and add to the collective knowledge of the economic impact in multiple regions or time points to assess how effective strategies can be to reduce the impact of skin cancers. Second, the study uses linked epidemiological data, which provides a rich source of data that the authors were able to draw from, while being logical and robust to assist with the minimization of false positives within the records. They also have used logical and internationally recognized diagnosis criteria for the diagnosis of both melanoma and non-melanoma skin cancers. This allows a thorough and comprehensive assessment of lifetime costs of skin cancers in New South Wales. The study had similar outcomes from other studies that they assessed. The weaknesses of the study included that the New South Wales Central Cancer Registry doesn't include the number of non-melanoma skin cancers, and the incidences were estimated from survey data. So to remedy this, reporting guidelines would need to be implemented for each non-melanoma skin cancer case which is identified. This would increase the number of cancers in the registry by 50-fold every year. In addition, the study then consider the stage of diagnosis, the treatment provided, the socioeconomic status of the patient. This would be of particular interest in the North Queensland Primary Health Network, as the stage of cancer at diagnosis would potentially be greater than in this study from the potential delays in seeking treatment due to limited access. There's also no consideration for the economic burden of the carer who provides vital care for individuals while at the same time limiting their own capacity for work. This is more difficult to remedy as there might be multiple carers assisting a patient at different levels, including families full-time caring during treatment to attending appointments with patients during the treatment of non-melanoma skin cancers. There's also the potential of including this in the 45 and up study to collect the data, though it might be incomplete. This study is a good example of aligning the structure of the article with the strengthening and consolidating health economic evaluation reporting standards. Cheers, checklist. Although the checklist is not an instruction manual for how to write an article, by following the guidelines in the checklist, the authors have been able to report their observations in a clear and concise manner that allows peer reviewers and others who wish to scrutinize their work. The article has a clear title, it has a well-structured abstract, the introduction provides clear context and background, the methods identify targets, population, subgroup, the settings and location are identified, perspective is shown, comparators are identified, the time horizon is clearly identified between 2004 and 2011, the discount rate is 3%. They identify their choices of health outcomes, they use the synthetic-based estimates for the measurements of effectiveness, their measurement and evaluation of preference-based outcomes are provided using a model-based economic evaluation. They don't provide any currency data and conversions. They explain why they use a regression model. They don't talk about any of the assumptions they make, and they also provide some detail on their analytical methods. They don't characterize heterogeneity, but their discussion is great. They list their findings, they describe their limitations, they also describe any limitations of the study, and they link it to the current knowledge that they found in the literature review. They also described their sourcing findings with the New South Wales Cancer Institute, as well as declaring conflicts of interest between them. Overall, this was a great article which provides evidence of the economic cost of skin cancer in New South Wales and closely adheres to the CHEERS checklist. So, what does this mean and how can we apply the findings of this study to our region? Well, the cause of skin cancers is known. Exposure to UV radiation, and comparisons can be made between the incidences of skin cancers in New South Wales and North Queensland. As you can see on this slide, the average solar UV index is graduated north to south, with North Queensland constantly being in the very high or extreme categories, while New South Wales in the low to moderate. This is even true for the winter months. Well, for 6 months out of the year in Townsville, the UV index is rated at extreme, which is 10.5 or higher, while just 2 months of the year it's rated at extreme in Sydney. As the effects of UV radiation is cumulative, this equates to a 1.5 times higher dose of solar UV radiation, so I would expect the incidences of skin cancer to be higher. Though the population of North Queensland is not as large as New South Wales, there are a number of challenges that present themselves and could potentially raise the incident rate of skin cancers, as well as the indirect costs, due to issues such as delayed treatment, travel requirements, limiting the access to healthcare, as well as the increased potential economic misfortune if a patient is unable to work after treatment due to the higher unemployment rate in North Queensland, which is 7.8 for the regional areas of Queensland compared to 5.9 in New South Wales. If you were to directly apply the outcomes of this study to the people of the North Queensland Primary Health Network region, there would be approximately 30,000 new cases of skin cancer each year, which would cost a total of $106 million, $72 million for non-melanoma skin cancers, and $33 million for melanomas. The costs of delivering solutions to skin cancer, such as slip, slop, slap campaigns providing shaded walkways, as well as regular skin checks, need to be considered as a viable option, as skin cancers are highly preventable, with the most effective means to be avoiding sun exposure to solar radiation at times of the day where the UV index is high or extreme. Society has known that exposure to sunlight can cause skin cancer since the early 1800s, and with the increasing global awareness, there's no longer justification not to implement strategies that will prevent this disease, which exacts such a high cost on individuals, communities, the healthcare system, as well as the greater economy. I would like to thank you once again, and I'm happy to answer any questions you may have. Or if you would like to flick me an email later, I'm happy to discuss this with you. Thank you.